Good evening, all. Welcome to ISA online PG class. Greetings from ISA National Headquarters. I, Dr. Naveen Malhotra, your own Secretary ISA National. Welcome to you today's PG class. Today we have amongst us Dr. Debashish Paul from Pune, and he shall be speaking and sharing his knowledge and expertise on tracheostomy and its implication for anesthesiologists. I hand over to Dr. Nishant Sahay, the coordinator for today's class. Welcome, Dr. Debashish Paul.
Thank you so much, sir. And every Monday, sir, we have our PG online classes, and this is more than the 50. We have had more than 52 such classes over the past year or so, and consultants and experts from all over the country spare their valuable time. And today is no different. Today we have amongst us Dr. Debashish, Lieutenant Colonel Dr. Debashish Paul, sir. He's the professor from the Department of Anesthesiology at FMC in Pune. He is an MD and DNB in anesthesiology. He's done his diploma in regional anesthesia and medical legal systems, and is a member of the National Academy of Medical Sciences. He's done his fellowship in basic pain medicine from Daradia in Kolkata, and is a certified pain and palliative care from the Indian Association of Palliative Care. He has various awards and the commendation card in 2009 for exemplary service in uniform.
I think there are some internet connections, so I'll continue from there. And he has been numerous academic achievements and experience and awards also. The commendation card in 2009 for exemplary service in uniform of the Indian Army. He has been felicitated by ISA Pune branch for exemplary worker as COVID warrior in 2021, and he received the certificate of appreciation from
Am I audible?
Nishant, we lost you in between, so you have to project the CV slide, and if there's some internet connections, then I'll do the honors for you. And I'm just sharing the slides again. Sorry for those technical things. And he has been.
Yes, sir. I think I'm having some internet issues, sir.
So he has been conducting workshops and hands-on training in regional anesthesia for students and practitioners, and he has been in charge of legal cell of Society of Defense Anesthesiologists of ISA, that is SDA ISA. And he has got numerous publications to his credit, including 13 original articles and 2 patents he has filed, and lots of awards from the GOC, IMC, commendation card in 2009 for exemplary service for the uniform in Indian Army. And his areas of interest are regional anesthesia, onco anesthesia, labor anesthesia, and pain management. And lots of academic achievements, awards to his credit. So welcome, Dr. Debashish Paul, and I request you to please start your talk on tracheostomy. In the meantime, all will be muted, and you can unmute yourself, Dr. Debashish Paul, now. Please unmute yourself.
Thank you, sir. Good evening, everyone, and thank you, sir, for your kind word. So I think I'll just share the screen, and then straight away we'll go to the case discussion part, sir. Okay. Yeah. So is it visible, sir?
Yeah, please go ahead.
Sure. Okay. Good evening, everyone. So today we shall be discussing, it's a very important topic as a part of wonderful initiative for MD, DNB postgraduate students. And tracheostomy and anesthesia are so interrelated that one can't ignore the topic. Even if you as a student don't encounter a case discussion on tracheostomy in your exam, you will have to do well versed with this topic in your professional journey as an anesthesiologist. So without wasting much time, let's get into the discussion. I'll prefer interactive discussions, and I have some MCQs or small or questions in between. And I know this is very difficult to do an interactive discussion when it is an online class, but I am available for discussion at any point of time in between the class, or maybe after class over phone or email, whatever mode is possible. Okay. So
Debashish, your video is not coming. Your picture, your own picture.
Sir.
Just see that your video is on.
Is it visible, sir?
Now you're visible. Please go ahead. Please go ahead.
Sir, the slides are not moving. I'll just share it again, and I'll again go ahead.
Click on any one slide, then it will start moving. Just put the cursor there and then press the arrow or the enter slide.
Yeah. Okay. So when we're talking about tracheostomy, your role is very specific. Your roles are very specific. You'll encounter cases of tracheostomy in the intensive care unit, or in the as a perioperative physicians in the perioperative management for tracheostomy cases. You'll also get cases as an elective or emergency or for percutaneous tracheostomy. In your exams, you might get a case as a short case, usually an adult patient, rarely a child will be given in your exams. And you have to deal with cases with comorbid patients for tracheostomy, along with some comorbid conditions like CA larynx, laryngomalacia, and patients with difficult airway, etc. So you should be very clear about the indications for the case that you are going to present. And now, before going to the main discussion, and what are the things you are expected to know? That one is you must know the anatomy for tracheostomy and cricothyrotomy. You might be asked about how to describe the anatomy of the larynx. What are the nerve supplies? Okay. So what are the nerve supplies? And then, as I've told you, tracheostomy and intensive care is a very important part. And your Viva can go into complications of tracheostomy, then tracheostomy tube care, then decannulation, etc. You'll also be assessed on your ability to demonstrate the knowledge for practical invasive procedures, especially the percutaneous dilated tracheostomy, with an understanding of the principles and hazards involved. And you might be asked about the emergency air management, including tracheostomy. And you should be able to describe the technique of percutaneous tracheostomy, including all the relevant anatomy and the complications. Now, before going into that basics, I'll just want to introduce you through a case scenario. let's have a case. Just there's a 35-year-old man who sustained a cervical spine injury, and he is present on ventilator dependent. He has undergone neck fusion previously, but now presents for a permanent tracheostomy. Now, what are the anesthetic and airway management consideration for this case? See, tracheostomy is the most common surgical procedure performed on critically ill patients. Establishment of an early tracheostomy is chronically ill patient. It actually helps to free the mouth for nutritions and for verbal communications. We'll learn about that, how they go for the speech part, and is associated with decreased morbidity and mortality. So that is a known fact. Now, this patient may present to the OR as an airway patient, or maybe sedated, or maybe an unconscious patient may or may not be on muscle relaxation conditions. Now, though surgical tracheostomy can be achieved in any of these states, general anesthesia with or without deep muscle relaxation is often preferred for patient comfort one, and to assure still surgical field. Now, if the patient is an unstable patient, the transition from airway to airway with a preserved spontaneous respiratory effort to an unconscious state with positive ventilation may manifest other underlying conditions. Like patient might be this thing. There's a high chances of cardiovascular volatility. So during tracheostomy procedure, the surgical team will ask you to do some steps. Like basically, they will be incising the trachea at the first to fourth intertracheal space, typically directly above an in situ endotracheal tube. Now, the anesthesia, as an anesthesia provider, you may be asked to deflate the endotracheal tube cuff, or to withdraw the endotracheal tube into the larynx to avoid the damage by the probing needle, tracheostomy hooks, scalpels, or electrocautery. Now, this part is very important. Please remember that electrocautery, because there's chances of ignitions of the endotracheal tube within the trachea, and it's a constant danger while the electrocautery is in use. And so you'll have to use a low inspiratory oxygen concentration. Ideally, it should be less than 0.3 of an FiO2, and should be maintained as tolerated by the patient. Now, because there's chances of prolonged duration for this tracheostomy, or there's a failed tracheostomy device placement, and you have to anticipate these things. So return from an FiO2 0.3 to 1, one should be considered once hemostasis has been achieved, and only after informing the surgical team, because it should be a closed loop communication, and this serves as a dual purpose. Basically, the timing of the appropriate return to a higher oxygen concentrations, and at the same time we alert the surgeons or the surgical staff that we are going to use 100% oxygen, and they should not unexpectedly use electrocautery in between. So these are some major issues. Now, once the trachea has been incised, and before the tracheostomy device is inserted, as an anesthesiologist, we may need to withdraw the endotracheal tube and suspend positive pressure ventilation. Now, the anesthesia circuit is disconnected from the endotracheal tube and connected to the tracheostomy device, and ventilation will be attempted. Now, how do you confirm that the tube is in position? So that your the end-tidal carbon dioxide, then look at the airway peak pressure, and obviously that bilateral breath sounds and the chest movements, all those things. Now, what will you do if you're not satisfied with the position of the tracheostomy tube? Now, should a satisfactory position of the tracheostomy device is not be verified, that is, there is no or minimal end-tidal carbon dioxide detections, high airway resistance, or the tracheostomy device, there is lack of bilateral breath sounds, straight away re-advancement of the endotracheal laryngeal position of the endotracheal tube can be attempted. Now, this may require some adjuncts like airway exchange catheter. So we can discuss about that. So this is the basic principles while managing a patient who has come to the OT with an endotracheal tube and planned for elective tracheostomy. Now, while managing, yes, one can go for the total intravenous anesthesia, or it's inhalational. Obviously, that inhalation will expose the surgical team to the anesthetic gases at the time of the trachea is incised. Now, minimal inspiratory oxygen concentration that I have already mentioned, which maintains the patient's oxyhemoglobin saturations. If there is a patient is hemodynamically unstable or poor cardiovascular reserve, then you have to inform the surgical team that you are going to use a higher FiO2 for these patients. And you have to remind them when the incision reaches near the anterior tracheal surface, because that's the time when they are likely to get exposed to a higher FiO2 if you are using that. So it's a closed loop communication with the surgical team. And above all, there is a constant vigilance is required. Now, if there is an accidental puncture of the endotracheal tube curve, that will lead to inadequate ventilations, leakage of oxygen into the surgical field, and again, it will lead to the chances of fire hazards. So in some of the practice, what they do, they after induction of general anesthesia and before surgical incisions, the patient may be extubated. They just remove the endotracheal tube and patient maintained by placement of a supraglottic airway device. So you have to consider that there is no contraindication for supraglottic airway device. I think so. You should be very clear about the contraindications for supraglottic airway device. You might be asked in the viva. So there's a risk of gastric content aspirations, upper airway mass, or any other distortions of the facial structures, or there is a requirement of high positive pressure. Now, the advantage of this supraglottic airway device placement is that it reduces it eliminates the risk of accidental surgical damage to the endotracheal tube curve, and obviously that airway fire. Okay, so now when we're talking about the potential hazards and complication in regard to airway, what are these? So obviously there is a conversion of the endotracheal tube to a tracheostomy tube. So there were brief or prolonged interruption of ventilation. Now, if your patient is unstable or patient is hemodynamically unstable, or there's a requirement of high FiO2, obviously patient is going to face some sort of complications, or there is a transient desaturations. So to take care of that, then what we have mentioned earlier, that about the fire hazard. So the surgical, the fire, it's a constant concern. So the surgical instrument field should always include water and irrigation syringe. And for a better safety, the entire operating room personnel, they should know the location of the fire extinguisher, should fire spread to the surgical drapes and other flammable items. Now, there is always chances that there may be iatrogenic false passage creations, and there are always higher chances of this creation of the false passage in some patients, which patients are on prolonged intubations, or patient is a case of anasarca. Then there is a chances of, because of some patient might be having a mucosal friability, prior midline surgical procedures or radiation therapy to the neck. So all these patients you have to consider, you have to think of that patient might develop some, might anticipate some problem while putting the tracheostomy tube. There might be a creation of the false passage. And so this is a really airway emergency. And this can lead to complications of the false tracheal passage, like pneumothorax, pneumomediastinum, then aspiration of the blood and secretions. So if we look at this, so what are the treatment options? The most important is there's an early detection of these conditions. And obviously they'll have to establish and secure the airway by removal of the tracheostomy device and with a definitive airway device without going through the passage again. And you can use some insertion of the other airway adjuncts like airway exchange catheter, or a small standard endotracheal tube with maybe of 6 mm of diameter, internal diameter, or you can use a rigid bronchoscope, and your airway cart, especially for the re-intubation, that should be ready. So, and as we have already discussed, that if there is any such incident, then just be ready to re-advancement of the endotracheal tube into the to secure the airway. So these are the questions and the situation that you are going to face in your exams or in your real life while managing a patient of tracheostomy. Patient is going for a tracheostomy with an endotracheal tube. So just to go back to the basics. Now, how does it help the tracheostomy, or what are the effects of tracheostomy, if I want to know? So basically the larynx is bypassed, and so the patient is unable to phonate. Okay, so patient is unable to phonate and until the speaking valve device is used. We'll talk about that later on. So there is decreased anatomical and respiratory dead space. So you all know that if you can reduce that anatomical and respiratory dead space, so that will reduce the work of breathing. So that will be good for the patient. Now there is a loss of the humidification and filtration function of the nasal mucosa. So it has got some implications. And there's an increased risk of respiratory tract infections. There is redundant area of the tracheal opening and below the larynx. So we'll have to do a proper suctioning of those areas. So we know that there are potential spaces where mucus can accumulate and fall back into the lungs. So that can lead to microaspirations. So one should be very clear about all these things. Now, and obviously the tracheostomy tube is a foreign body, so there you can anticipate some foreign body reactions with some local inflammation in some of the patients. Now coming to the basics of tracheostomy. Now tracheostomy, we all know it's an operative procedure that creates a surgical opening into the cervical trachea. Now, what is the basic difference between tracheotomy and tracheostomy? Now, when we talk about tracheotomy, it's a surgical procedure that opening is made in the anterior wall of the trachea just to gain an access to the airway, which is temporary and reversible. But when we talk about the tracheostomy, it's the literal meaning is that mucosa is brought into the continuity of the skin with the opening of the trachea. And this is most often, but not always, it's a permanent thing. Okay. So coming to that, the landmarks. As I have already mentioned in this thing, you are expected to know all this, your anatomy, the physiology, the anatomy landmarks. So the three important landmarks which can be palpated easily through the skin for both tracheostomy and cricotherapy are the following. So what are those? The one is your thyroid prominence or Adam's apple, which is the uppermost landmark and the most prominent in males and less prominent in females. I know you all know these basics, but I'm just revising this because there are things where you can't you might be asked and you'll have to be very thorough during your exams. Now, just below that, we have the cricoid cartilage, which is felt, which is the shape of a reverse signet ring. And what is the next thing to be palpated is your sternal notch. Okay, so now I have got a question for you. Now, this thyroid cartilage is located and stabilized between the thumb and the forefinger. Now, while doing tracheostomy. So the most important anatomical landmark identified out of all these, which is the most important. Now, one is the thyroid cartilage and sternal notch. Another is cricoid cartilage to sternal notch. Then tracheal rings. One is cricothyroid membrane. So can I expect some answers for that?
So may I repeat the question for you? I'm Dr. Monica. I'll be
please.
moderating the session. So the thyroid cartilage is located and stabilized between thumb and forefinger. The most important anatomical landmark identified is thyroid cartilage and sternal notch, cricoid cartilage and sternal notch, tracheal rings, cricothyroid membrane. We have some answers, sir. Dr. Ambili, Shishant, Ankita are saying 1, that is thyroid cartilage and sternal notch. And 2 people have said number 2, cricoid cartilage and sternal notch. We are getting 1 and 2.
Ma'am, thank you, ma'am. So just moving ahead. Okay. So actually the most important, this is the number 2, that is your midpoint of the line joining the cricoid cartilage and sternal notch of the extended neck. Actually, it marks the insertion of the site which corresponds to either the tracheal ring 1 or 2 or 2 or 3 tracheal rings. So this is the ideal site for tracheostomy. Okay, to give the incision. So see, we all know this, but sometimes we misinterpret. So we'll have more MCQs so we can answer rightly. Now moving to the next thing. Okay. Now the cricothyroid membrane, so we all know it's a very important structure for the anesthesiologist. It is in between the thyroid cartilage and the cricoid cartilage, and it's an indentation between these 2 cartilages. Now we all know the trachea is made up of some semicircular cartilaginous rings and anteriorly and laterally, which can be palpated percutaneously in a thin person. Now both the spaces between the rings and the posterior aspect of the trachea are membranous. So this is very important. Someone can answer in the chat box why this is very important, because it is absent in the posterior aspect of the trachea. So it is membranous. Okay. So now coming to the next thing is there is a isthmus of the thyroid gland, which lies anterior to the trachea at the level of the second to fourth tracheal rings. Now this isthmus and the trachea are covered with pretracheal fascia. So this is these all structures are very, very important when you are presenting a case of tracheostomy. Now we have to know a little bit about those muscles, like the staph muscles on both sides, which meet at the midline and which needs to be separated during tracheostomy. And there is a muscle, this is a platysma. It's actually broad sheet of muscles arising from the fascia. If you look at the picture, and it's covering the upper parts of the pectoralis major muscles and deltoid muscles. Now these fibers cross the clavicle and proceed obliquely upward and medially along the side of the neck. So this leaves this inferior part of the neck in the midline deficient in significant muscle cover. It's actually superficial muscle of the neck, and it overlaps the sternocleidomastoid. So if you look at it, when it contracts, it produces a slight winkling of the neck, or it's something called boasting effect on either side of the neck. Now under this platysma, there is an anterior jugular veins that runs parallel to each other near the midline. Now these veins can cause troublesome bleeding while doing a tracheostomy. So to remember these veins while doing a tracheostomy. Now then the most important structures, the recurrent laryngeal nerves and the inferior thyroid veins, they lie in the tracheoesophageal groove and are paratracheal structures. So I think you should have a fair idea of these anatomical structures. Now coming to this picture, this slide, you can see that the hyoid bone, which is an attachment to the epiglottis and the strap muscles. Then we've got a thyroid cartilage with an anterior attachment to the vocal folds. There's a posterior articulations with the cricoid cartilage, and then the cricoid cartilage, as we mentioned, it's a complete ring. It articulates with the thyroid and arytenoid cartilages. If you look at the picture that on this side, that you can see that cricoid cartilage is sort of posteriorly it is attached to the arytenoid cartilages, and it's a complete ring. Now these arytenoids are important because these are the two cartilages that actually glides along the posterior cricoid and attached to the posterior ends of the vocal cord. Now we must know a little bit about these divisions. I can skip these slides, but I think it's better if we have fair idea of these structures, like what in the trachea, there's a supraglottic part, which is covered mainly with the respiratory epithelium containing numerous mucus glands. Then we have got the epiglottis. You have seen in the previous slide that the epiglottis, it's a leaf-shaped mucosal covered cartilage, and it projects over the larynx. Then we have got aryepiglottic fold. It extends from the lateral epiglottis to the arytenoids. So why I'm going through this, because you should have a clear idea about these structures, not only for your exams. As an anesthesiologist, you must have a fair idea. Now then we have got false vocal cords. Then the ventricles. Ventricles are mucus lined sac, which are variable sizes, and which separates the supraglottis from the glottis. Then the glottis, which is the there's a true vocal cord. It is which is the bulk of the vocal fold, is made up of muscles covered by the mucosa. The true vocal cord is attaches to the thyroid cartilage at that anterior commissure of this glottis. And these vocal folds abduct for inspiration and adduct for various functions like phonations, for coughing, or to do an Valsalva maneuver. So all these things. And then we have got the subglottis. It is below the vocal folds, extending to the inferior border of the cricoid cartilage. Now, one must remember that this, when you're talking about all these structures, one thing you can't forget, that is the motion of the arytenoid effects with the abduction or adduction of the larynx. So to consider the respective position of these folds and the cartilages and their functions. Now, this is another important thing, that is the innervations. So we must know about the branches of the vagus nerve. This is the and what are those? These are mainly the superior laryngeal nerve, and then another one is recurrent laryngeal nerve. Now, superior laryngeal nerve. Now, this is basically sensory to the glottis and the supraglottic part, and motor fibers to the cricothyroid muscles. And cricothyroid muscles, we all know that it tenses the vocal folds. This nerve leaves the vagus very high in the neck. Okay. So, and when we talk about the recurrent laryngeal nerve, It is a sensation of it is a sensitive to the subglottic part and motor fibers to all the intrinsic muscles except that we have already mentioned that precautions, that is the supplied by the supralaryngeal nerve. Now, this nerve branches from the vagus in the mediastinum and then turn back towards the neck. So you can see in this picture, on the right, it travels inferior to the subclavian artery, and whereas in the left, it is just travels inferior to the aorta, and then it goes to the this thing on that on the groove. Okay, so just to summarize, you must know about all these cartilages. These are paired and unpaired. We have got 3 paired cartilages and 3 unpaired cartilages. So we have got total 9 cartilages. Now, a little bit, if you want to do well, very well in your viva, so you must know a little bit about the history. Now, the history of surgical access to the airway is largely one of that's a semi-slaughter that Fabricius could write in the 17th century. So just go through this all the history part, and you that the other name that Chevalier Jackson that described the principles of tracheostomy at the beginning of 20th century. In fact, if you see that Chevalier Jackson in the year 1909 described the modern technique of surgical tracheostomy, and since then it has been extensively used in intensive care units and patients in the intensive care unit to establish a long-term or emergency access to the airways. Now coming to the other guys, that Sheldon and colleague in 1957 and Toy and Winston in 1969, they described the technique for Percutaneous tracheostomy for the first time. So if you have been asked who is the guy who first described the techniques of Percutaneous tracheostomy, you should mention about these 2 names. And then the classical technique of PCDT or percutaneous dilation technique using progressive dilators was introduced by Ciaglia, and this all and in 1985. Then followed by Griggs et al. In 1990, who introduced us to the one-stage dilation technique using a modified Howard Kelly forceps as a tracheal dilator. So there are lots of things, interesting facts in history. Now coming to the now after finishing the basics of anatomy and physiology and and the history, now we can come to the tracheostomy. Now it can be either emergent. Now when we talk about emergent, this technique is basically slashing the throat to save the life. And that I have already mentioned that it is also known as semi-slaughter. This should be considered only when the patient is in extreme, when an emergency or distress and impending death of the patient exists. Now this is Now this is this is usually the exact indications of thyroidotomy. The complication rate for emergency or tracheotomy is as high as 20%. Now coming to that urgent. Now this is indicated when the patient is in respiratory distress, like stridor, and needs immediate surgical intervention. This can be performed in controlled environment, whether in the ICU or in the operating room, with the patient under local anesthesia. Now, the patient's anxiety and restless movements, these are going to challenge the surgeon and the anesthesiologist. However, constant vigilance is required to maintain the airway. Now, this patient should be minimally sedated. So that's why under minimally sedated under local anesthesia. So this, we go for urgent tracheostomy. Now, when you talk about the elective, most that you have seen in the first case scenario, most elective tracheostomies are performed on patients who are already intubated with the disease conditions requiring prolonged intubations or ventilations. Now, undergoing extensive head and neck procedures to facilitate airway control during convulsions, or with chronic pulmonary problems like patient is having a sleep apnea. Okay, so now there are 2 methods while performing the tracheostomy, that is open bed-sided or open tracheostomies, or we can denote it as OBT, which involves a full dissections and of the petechial tissues and the insertion of the tracheostomy tube into the trachea under direct vision. Whereas in PDT or percutaneous dilatation tracheostomy, needle guide wire is being used to gain the airway access, followed by serial dilatation of the stoma. Now, when I'm talking about the dilators, different methods are used for dilatation of the stoma. Now, you must remember the names at least, or the techniques like multiple dilators, modified Howard Kelly forces that we've already mentioned, and the Griggs et al. Technique. Then we have got the rapid track dilating forces. Then Ciaglia one-step loading dilator or tracheotome. Now, all methods involve use of blunt dilatations to open the pretracheal tissues for passage of the tracheostomy tube. So I think we have got a fair idea now what is open tracheostomy and what is now. Historically, it was thought that it is appropriate that the procedure should be performed in the OT because of the need of the adequate lighting, instruments, and support facilities, and the association with and since these procedures are associated with high morbidity and mortality, so it's better to get it done in the OT or in a controlled environment. However, the problems including the hazard of moving critically ill patients to the OT, then the associated cost, the staff, and the inconvenience of the OT schedule. So after considering all these, now proponent of Percutaneous dilatation tracheostomy suggests the few advantages. Now, what are those? So one is it's a rapid, simple, easy to learn, and cost effective. Limited dissection, so less tissue damage. Chances of lower risk of bleeding and wound infection, and able to be performed at the bedside in the ICU, which may overcome the risk associated with transportation of critically ill patients to the OT. Now, and there is less delay in performing the PDD, which is a better cosmetic sequelae. But one should not forget the complications, which are short-term and long-term, especially in while going for percutaneous tracheostomy. Like this short-term, a patient can go into hemorrhage. That is that I've already discussed. Then there is a problem with the decannulations or chances of obstructions. Then false passages, especially those patients we have discussed. Then long-term complications, one must know that patient can develop scar development, tracheal cutaneous fistula, subglottic stenosis, wound infection. So apparently it seems that it is superior to the open tracheostomy technique, but these problems you should consider. Now, if I don't speak about this, because you must know what are the indications for tracheostomy. So now you go one by one. Now, when you talk about the upper respiratory obstructions, we can consider the infections, trauma, neoplasms, foreign body damage, laryngeal edema. Like in laryngeal edema, like patient is having allergy or fumes or any initial poisoning or radiations. Then we have got cases like bilateral vocal cord pulses. Then congenital anomalies like laryngeal waves, cyst, tracheoesophageal fistula, bilateral atresia. So all those things you should consider when you've been asked about the indications. Now coming to that other indications like mechanical or respiratory insufficiency, like acute respiratory failure. Patient might be a case of trauma because of some head or neck trauma, and that results in resulting into severe injury to the thyroid or cricoid cartilage or hyoid bone or gate vessels. Then facial fractures that will lead to upper ear obstruction, especially the cumulative fractures of the mid face and mandible. So please remember that since all this thing attending that operation theater where the maxillofacial cases are done, so the leaf for 3 type of fractures where this is a indications for going for tracheostomy if the other condition allows. And then the neurological considering other factors. Now neurological diseases like Guillain-Barré syndromes, myasthenia gravis. Patient might be having because of some spinal injuries, then poliomyelitis and polyneuritis and chronic obstructive and then the chronic obstructive airway diseases. So these are all if you in this sub-classification in the mechanical and respiratory insufficiency group. Now, when you talk about the respiratory difficulty, like patients, few patients who are unable to cough, like patients in coma due to head injury, CVA, or narcotic overdose. Patient might be a case of paralysis of the respiratory muscles, as in spinal injuries, Guillain-Barré syndrome, myasthenia gravis, because of some respiratory muscle spasm, as in tetanus, eclampsia, or strychnine poisonings. Then patient might be having a case of chest injuries or pneumonia, where patient is difficult to cough out the secretions, a painful cough. And then there's a chance of aspirations because of the pharyngeal, excessive pharyngeal secretions in poliomyelitis, polyneuritis, or laryngeal paralysis. And we've already mentioned that to provide pulmonary toilet. In some cases, prophylactically, we go for a tracheostomy, like to provide a patent airway and upper airway is potentially at risk, as for example, surgery on the oral cavity, pharynx, or larynx. So I think I could enumerate all the indications for tracheostomy. Now, you might be asked in the exam, so what are the signs and symptoms suspected in an airway obstruction? So you have to rattle out all these things like dyspnea, then stridor, whether it is inspiratory stridor or expiratory stridor, or it's a biphasic. And then going to suspect if there is any voice change along with, obviously you are not going to treat these symptoms in isolations. You have to consider the multiple factors. So, but you just rattle out all these things like decreased or absent breath sounds, and chance of bleeding from that area, the drooling, restlessness. And obviously, if a patient continue in a state of hypoxia for a longer time, patient will have hemodynamic instability followed by there's some neurological symptoms like loss of consciousness in a late stage. So now, since we have spoken about that indication part, now let's go to that contraindication. Please remember that tracheostomy, we have got only the relative contraindications. Now, like what are those? Like emergency airway access. Because these relative contraindications, they are subject to experience and clinical judgment of the operator and not set in stone. So emergency airway access, if you've got difficult anatomy like morbid obesity with a short neck, limited neck movement, cervical spinal injury, suspected or otherwise aberrant blood vessels, thyroid or tracheal pathology. Once you mention about that aberrant blood vessels, so examiner might ask you what is the I'm not going into details into that. I'd be that nowadays the application of ultrasound for the front of neck axis. So you might get your Viva can go into that line. Now then coming to the moderate coagulopathy. So what are the ideal coagulation profile to go for the tracheostomy? Significant gas exchange problems, like if the patient is on high PEEP, more than 10 centimeter of water, or FIO2 requiring for more than 0.6, and evidence of infection in the soft tissue of the neck at the insertion site, and age less than 12 years. We'll talk little bit about the pediatric tracheostomy, but just consider that these are all relative contraindications for percutaneous tracheostomy. Okay. Okay. So.
There's another MCQ. Yeah. Which of the following does not contain a speaking valve? Vortex tube, Shelley tube, Traco, Bivona, or Nicus? You can type your answers in the chat box. Yeah, so Dr. Rohit says 1. There's another doctor who is saying number 1, that is Vortex. Yeah, number 1, Dr. Prabhakar. I think all are for 1. That is Vortex tube.
Oh, I think they have not read the question. Which does not contain a speaking valve? Yes, Vortex is 1, but there are these manufacturers. They have also come up with the tracheostomy tube which contains the speaking valve. So the answer should be very specific. Now, out of all these, this Bivona is the is the right answer. So don't worry. Now in another 2 to 3 slides, we are going to discuss about the tracheostomy tube, because you might get your table viva on this. So okay. Now I've got another questions. Now please identify these.
Anyone, can you please identify this?
Obviously, I can't give you a choice for this.
Something used in percutaneous tracheostomy. Bullhorn, blue rhino. Yeah.
So it's excellent. It's because you know the things. Okay. So now you must know this table. Now, what are the makes of this tracheostomy tube? Obviously, on the right hand side of the slide, you can see that blue rhino single stage dilator. It is mainly basically made by the Cook Medical Company. Now, I know these are very confusing, but please go through this slide and just try to remember this, because what are the different types of make, like Vortex, Shelley, then Traco, Bivona, and Nigas. And if you see that in all the types, you have got this thing, they produce the fenestrated tube, except that Vortex, because they also come up with the speaking valve. They have the different types of speaking valve, but rest of that they produce fenestration tube, and these are helps for acts as a speaking valve. Now you just read about that, what are the materials they use, and whether they have got an inner tube or outer tube. So you see on your this thing in institute what a sort of tracheostomy tube they are going to keep it on the table for your table viva. So please go through that. I'm just going to the next slide. So if you can see this now, if you see that first picture, what is this? This is actually standard single cannula. and size 7 tracheostomy tube. And if you look at the picture number 2, it's a standard dual cannula tracheostomy tube. You can see that introduced also. And then this is the third picture where you can, this is a fenestrated tube and dual cannula. Can you see these fenestrations? And it is mostly in the posterior wall of the inner tube. So please try to remember these pictures. And then what is this? This is an adjustable flexible tracheostomy tube. This is the fourth picture. And here comes that this is a very favorite question of the examiners. So there's a speaking valve. So you have to ask you will be asked, please name one of the speaking valve. So there's a very interesting story behind this. So you can read about that. I'm not going to discuss that. So this is called Pessi-Muir speaking valve. So this is inserted into the external orifice of the tracheostomy tube. Those who are interested, and you can read about this. Okay. So coming to that tracheostomy procedures. And now this open procedures and you can see that this is the percutaneous tracheostomy procedures. Now the common points between these two procedures. Now don't think why, as an anesthesiologist, why should I know the surgical step? Because you have to be constantly vigilant about the cases. There are multiple you have to intervene, so you must know the steps. Now the common points between and as an anesthesiologist, you are going to do percutaneous procedures. Now, what are these common points between both these procedures? Like intravenous sedations with the type and doses of medications, which are basically decided by the clinical needs of the patient. Now, both the procedures can be done in the ICU or the operating room. Then the most important thing, written or verbal consent prior to the procedure. Please don't forget about that. Now, then check the patient coagulation status. The patient should receive 100% oxygen at least for 10 minutes before the procedure. Patient should be monitored. The standard monitoring like SpO2, EtCO2, ECG, and the pulse oximetry, and the BP and temperature. So don't whether you use it or not, please mention about that, because now I have seen people forgetting the temperature part. This is ASA standard monitoring. When you talk about, so you have to mention about the temperature monitoring. Now, in cases the patient is already intubated before the procedure, to avoid injury to the cuff, any of the so you can do some things which can prevent the injury to the endotracheal tube cuff. Now, one is that we withdraw the endotracheal tube to a point just proximal to the tracheostomy opening. The cuff, it lies just above the vocal cord. So distal to the vocal cords, and is no longer in the trachea. Now this, but if you pull it above the vocal cord, it creates a substantial leak, and patients experiencing severe hypoxic respiratory failure may deteriorate during this procedure. So you have to consider the condition of the patient. Or we can transilluminate the tip of the endotracheal tube with a flexible bronchoscope that is briefly inserted into the tube. And nowadays, examiners are very fond of this thing, asking about that role of the bronchoscope and using a fiber optic bronchoscope while doing a tracheostomy. So you must be conversant with this. Now, this may help prevent inadvertent injury to the membranous posterior tracheal wall or to lateral and location of the tracheum. Now, I think during my introductory slides, I asked about that. What is the relevance of this membranous posterior tracheal wall? So when you do the fiber optic bronchoscopy, that actually helps you to find out which is anterior wall and the posterior tracheal wall. So please remember that. Now, this helps to localization, and this localization actually may be repeated during the procedure, and this decreases the risk of hyperventilation. Patients who require tracheostomy only for airway access or protection often can have a laryngeal mask airway, replacing the endotracheal tube that I have already mentioned while discussing our case scenario. Now, this also provides a route for bronchoscopic visualization. So you can actually use that bronchoscope through that esophageal carrier device. Now, coming to the position, the neck is extended by placing a good bolster underneath the shoulders, and the awake patient can be positioned in a sitting or a semi-recumbent position. Now, coming to the local anesthesia, the first 3 tracheal rings are identified, and lignocaine with 1:1 like epinephrine is infiltrated. That is, and this is sufficient anesthesia if you consider if you want to do a awake tracheostomy. and to facilitate hemostasis in all patients. Now, if the tracheal rings are not palpable, then a point between the cricoid cartilage and the suprasternal notch is marked. So you can go back to that our MCQ1. Okay. So now that once the anterior neck is prepared with some prepared aseptic precautions should be taken. You can prepare that area with the povidone iodine and taped with sterile sheets. The tracheostomy cuff should be properly checked or leaked. So it is whenever you use any equipment, you check it before using it. So all the kit should be checked. Tracheostomy tube size and confirmation that the tracheostomy tube is in the trachea and so once that is over and you have so now some practical tips. How do you identify that the tracheal tube is in the position or not? So you can see that we have already mentioned that anterior carbon dioxide waveforms. You can look for the bilateral bed sounds, or sometimes you can put a piece of thread in front of the tracheostomy tube lumen and see that outer displacement of the thread during expiration. But actually that is not significant, but inward drawing of the thread during inspiration confirms that tube is in the trachea. So these are the small practical tips. Okay, so now coming to that, this is very important. Now coming to the incision. Now the type of tracheal incision applied dependent very much on the primary indications and the estimated duration of tracheostomy and the preference of the surgeon. Okay, so if we go for a vertical midline incision. So vertical midline incision between the lower body of the cricoid cartilage and the lower body of the cricoid cartilage and suprasternal notch. This is easier, gives a rapid exposure, and is usually used by the emergency tracheostomy, relatively safer than the crease incisions. Now horizontal incisions gives better cosmosis and is done in semi-emergencies. It should be done at midpoint between the cricoid cartilage and suprasternal notch. In adults, it is roughly 2 cm above the around 2 cm above the suprasternal notch. Now, during this procedure, meticulous hemostasis is the most important point. So then, when we talk about the hemostasis, if surgeon wants, they can use the electrocautery while doing the dissection, and then your viva again go back to that fire hazards. What are the precautionary measures to be taken? So all those things. Okay. So now the dissection proceeds through the platysma until there is a midline elbow between the step muscles is identified. Now the step muscles are separated vertically by blunt dissections and retracted laterally, exposing the pretracheal fascia. You can see in this picture exposing the pretracheal fascia and the thyroid isthmus. Midline dissection is essential for hemostasis and avoidance of injury to the paratracheal structures. Now, what are those paratracheal structures? Just go back to our anatomy. These things slides. You can injure the nerve or the important vascular structures. Now, the lateral retraction also serves to stabilize the trachea in the midline. The use of cricoid hook to stabilize the trachea in midline is also recommended. Okay. Now coming to the tracheostoma, it can be T-shaped. Just remember the names. You don't have to get into all these things, but just remember the names. It can be T-shaped tracheal opening, or it's a walk flap, or A-shaped tracheal opening. This is actually beneficial in patients with obesity. So you can always test the knowledge of your surgeons while giving this, when making this tracheostoma. So, however, there's a risk of persistent tracheocutaneous fistula. And circular excision of the anterior tracheal wall, which is the very common this is the most popular thing out of the usual practice of circular incisions of the anterior tracheal wall. Basically, it consisting of 2 tracheal rings and placement of a tracheostomy tube. Now, in case of children, it is always advised to give a vertical incisions in the midline of the trachea from the 2nd to 4th ring and pass 2 stay sutures of 0 silk on either side to bring it out onto the neck for taping it. Now these sutures will help in replacing the accidental dislodgement of the tracheostomy tube. When discuss a little about the pediatric tracheostomy, so you will come to know that the most common complication is accidental dislodgement in a pediatric tracheostomy tube. tracheostomy cases and early insertion. So advantage of vertical incision is that it prevents tracheostenosis when decannulated. Okay, just remember that. So advantage of vertical incision is that it prevents tracheostenosis. So that is also very common in pediatric cases. Okay.
So
yes, ma'am.
yeah. There's a question. When will you desire a permanent stoma? Any answers? You can please type them in the chat box. So when is permanent stoma required? So Dr. Zoya has answered during laryngectomy.
Yeah. So she is right. So this is mainly desirable only in patients who are expected to require to secure a transluminal access for an indefinite period of time, like patients with sleep apnea or terminal illnesses or post-laryngectomy. So the resecting part of the anterior tracheal wall, it can predispose to stenosis. Thus, this resection is normally not done in a temporary tracheostomy. Okay. So okay. So once the trachea is entered, the tracheal dilator is used to maintain the patency of the opening of the trachea, and suctioning of secretions and blood out of the lumen is done. Now, once you place the tracheostomy tube or insert it with the tracheal dilator, so basically you're just widening up that opening into the trachea, and wound should not be closed too tightly. A surgical emphysema can develop. The flanges of the tube can be sutured to the neck. So these are the steps we normally see in the OT or in the ICU. So we know, and once you confirm the tube is in the trachea, that is the time when you will secure the tracheostomy tube to the skin with the permanent sutures. So sometimes you can you'll have to teach the surgeons also. Okay. So now. So if you look at the this thing, when you talk about the Percutaneous tracheostomy insertion, a 1.5 centimeter vertical incision made over the skin, mainly overlying the second or third tracheal rings, and blunt dissection is performed to expose that pretracheal fascia. Now, once the anterior trachea is palpated and the intended site is punctured with a 14 IV cannula in the postoperative direction, so you can see the direction. It's the postoperative direction. Now that the entry of the IV cannula or the needle in the trachea is confirmed by aspiration of air into a lignocaine filled jelly, and then air is aspirated. And once you are confirmed, once you are confident that yes, it is in the right place, so you can inject about 1 cc of the drug. Now, next thing is you can place the guide wire. It is inserted through the cannula, and the cannula is withdrawn. Thereafter, the tracheal opening is dilated over the guide wire. So we have already mentioned about that. Now, the different methods to dilate the trachea. One is a serial dilate technique. One is your Greek's guide wire dilating forceps technique. One is the rapid trick. Then some people have rightly identified that Siaglia blue rhino dilator technique or the dilators. So when we talk about the Siaglia blue rhino dilator technique, it is the after the guide wire is protected, the blue rhino single tapering dilator is introduced over the guide wire until that stoma is dilated to an adequate diameter. So it is around 36 French to 38 French. Once dilatation is achieved, the tracheostomy cannula is assembled with one of the three intermediate dilators. So you can read about all these the different techniques and what are considering your table viva, if you have got this one of this kit, so you can read about all these things. Okay, so then. Okay, you can see that that is the groove for guide wire, and there is the sharp technique. It goes in the posterior directions, and then you have got a tracheostomy tube. Then there's a dilator, and that is placed over that guide wire, and this is the serial dilator technique. Okay, okay. So now we have got just for knowledge, you should know about little bit of the Fentanyl dilating tube, then Parquet twist. So Fenestrated, it was an attempt to prevent membranous tracheal wall injury. Basically, there is chances that the posterior tracheal wall might get injured because there is a deficient of tracheal ring on that side, and to protect the anterior rings from the fracture. So this technique was introduced with a special dilating tube which was used and placed translaryngally through the trachea and pulled out rather than forced in. But this technique is very complicated and there are mixed reports regarding its success. So nowadays people don't do it. And then we have got a percutaneous twist. It is another attempt to solve the excessive force problem with the percutaneous dilatation technique. It is basically the screw action dilatation, and that was designed to allow the dilatation of twisting while lifting the trachea rather than pushing it down. So there are various techniques just to protect the, just not to harm the patient, not to injure that vital structures. And in the percutaneous twist, the tracheostomy tube, once it is dilated, then the tracheostomy tube is then inserted over the guideway. Dilator tool is removed and the tube is inflated and secured. And again, the basic principle is same. Once the lungs is checked by chest auscultations, you confirm the position of the tracheostomy tube, then only you go ahead. So little bit about, you must know about that other procedures like mini tracheostomy. These are mini tracheostomy tubes are around 3.5 to 4 millimeter diameter. These are cuffless tubes inserted percutaneously through the cricothyroid membrane. So please remember that when you talk about the mini tracheostomy, it's basically through the cricothyroid membrane, usually under local anesthesia. Now the technique is a cell danger technique for introductions of the mini tracheostomy tube, it's basically allows to do suctioning the secretions with a need for formal endotracheal intubations or tracheostomy. Okay, so the other technique that you must know a little bit about that is one is cricothyroidotomy. So this is a maybe preferred in life-threatening upper airway obstructions where endotracheal intubation is not feasible and there is insufficient time to perform tracheostomy. It is generally performed under local anesthesia. A full-size tracheostomy tube can be inserted to facilitate mechanical ventilation. So in emergency conditions, temporary oxygenations, and temporary means I'm talking about around 30 to 35 minutes, and can be aided by this intermittent insufflation of 100% oxygen at around 15 liters per minute with a pressure of 50 psi via a 14-gauge cannula inserted through the cricothyroid membrane. Interruption of oxygen flow is basically regulated by a simple Y-piece adapter. You can see here. Okay, so this is this Y-piece, Y receptor. And this is something I wanted to show because this is normally we prepare for the jet ventilations. This is not a 14-gauge cannula. This is a 16-gauge cannula. Ideally, it should be a 14-gauge. And with a 2 ml syringe and with a universal connector around 6 inch diameter, 16 inch diameter, and that is connected. And you can also connect it to the oxygen source. So normally in these type of cases or patients, we always ensure that this is prepared and kept somewhere for the jet ventilation. So you can always do that. Okay. Okay. So after these surgical steps, we must know a little bit about the complications of tracheostomy. So when you talk about the complications, the examiner would like to listen if you divide it into different headings like immediate complications, then the intermediate complications, and then the late complications. So they will come to know that yes, you have gone through your approach is always systematic one. So immediate complications, hemorrhage from either injury to the thyroid gland or injury to the anterior jugular veins, and sometimes the thyroid arteries. Apnea, yes, apnea may occur, that you already mentioned. It can, there's a brief interruption or the ventilation. And in sudden apnea also may occur in patients with prolonged respiratory obstruction. Sudden washout of carbon dioxide eliminates this hypoxic drive. So once this thing, there's sudden illness, there's sudden lesser work of breathing, and you will be able to ventilate. So there will be sudden washout of the carbon dioxide, and it actually eliminates that hypoxic drive. Now, it can be treated with carbon dioxide, 5% carbon dioxide in oxygen. So the other things you can read about, and then patient might go into cardiac arrest. Then chances of air embolism, pneumothorax or pneumomediastinum, which can result from injury to the adjacent structures. That I would mention that it can be because of a false track, and it can be because of the direct injury to the hyoidoma pleura or lungs, especially in children. Okay, so so early recognition is critical, and routine post-operative chest radiography should be considered after tracheostomy. Now, when you talk about that injury to the adjacent structures, that injury structures are recurrent laryngeal. Examiner might ask you what are those structures. So these are recurrent laryngeal nerves, the great vessels, and the esophagus. This danger is most in the children because the softness of the trachea it hinders its identification, and it is if it is not distended with rigid object like endotracheal tube. Then post-obstructive pulmonary edema may occur, though it's very rare. Now, coming to that intermediate complications is dislodgement and displacement of the tube. A tracheal dilator should be available all the time in the ICU. You have done a good case and you have kept the patient in the ICU, but if you don't know what are the likely complications, that that will be very difficult because you have to anticipate these things and to prepare it accordingly. So tracheal dilator should be available all the time in the ICU, and especially it is kept in the emergency crash cart. Inserting the tracheal dilator and opening the tracheostoma by the ICU nursing staff can actually save a patient's life. Okay. Then we might have surgical emphysema, which can result from tight closure of the tissues around the tube, or because of tight packing material around the tube. It has been discussed so many times that because of the false passage of the tube into the pretracheal tissues, which can lead to pneumothorax or a pneumomediastinum, mainly recognized by the mediastinal crunch. So treatment is by loosening the closure or tight packing. Usually, the surgical emphysema subsides into 2 to 3 days time. Since tracheostomy tube is already present, respiratory embarrassment would not occur. But and post-operative chest radiography is recommended for this. Okay, so then you might have patients who develop tracheitis or tracheobronchitis. So so in some degree of patients will have tracheitis with fresh tracheostomies. Now, that factors which can increase the incidence of tracheitis are: one is your lack of humidifications. Then there is an increase in the fraction of inspired oxygen because of high oxygen exacerbates drying, and irrigations is essential part. Then there is a motion of the tube within the trachea in high altitude areas and places where the relative humidity is less. The intensivist should be meticulous about humidification. Otherwise, there will be severe crushing inside the tracheobronchial tube, which can lead to the fall in the SpO2. So when I'm talking about high altitude areas, since unfortunately I've got experiences of this thing managing patients in high altitudes, so there one should be very careful because of the lesser relative humidity in those places. So then this crust needs to be removed with the help of a rigid bronchoscope if required, and this will be passed through the tracheostoma. Okay. Then the patient might develop some cellulitis because there's a wound very quickly. However, infection is unlikely if the incision has not been tightly closed and drainage is allowed. So opening of the wound and instituting appropriate antibiotics should suffice to treat any early cellulitis. Then other complications are tracheoesophageal fistula usually occurs either while doing a tracheostomy or while inserting the tracheostomy tube forcibly. Dysphagia, atelectasis or lung abscess, mucus plugging of the tracheostomy tube. The use of dual cannula tubes makes this less of a threat because of the inner cannula can be removed for cleaning while the outer cannula safely maintains patency of the fresh tract. So these are the advantages of putting a dual cannula. Then patient might develop early bleeding. This is the result of raised blood pressure when the patient emerges from the anesthesia and begins to cough. So I think you all have encountered this while managing patients. It may be controlled local packing around the tube and control of hypertension. Now, you can some people use a packing with antibiotic impregnated gauze and all those things. So these are the immediate complications. Now, when you talk about the late complications, basically tracheal and laryngeal stenosis. Injury to the cricoid cartilage, the only circumferential ring in the trachea. See, every time there is some relevance of this anatomy. This is very interesting. So injury to the cricoid cartilage, the only circumferential ring in the trachea, which it can lead to the tracheostenosis. Now, tracheostenosis typically occurs in the site of tracheostomy or at the area irritated by the cuff. And modern high volume low pressure cuffs have reduced this rate of these complications. So nowadays we are using high volume low pressure cuffs. Okay, our care still must be taken not to overinflate these cuffs and to let them deflate periodically. So one should be very careful while managing patients in the ICU in a tracheostomized patient. Ideally, after 4 to 6 hours of tracheostomy, the cuff should be deflated, except under few conditions. So, what are those conditions? If there is an active bleeding from the stomal side, then if the patient is on ventilator, and then patient is an increased chances or predisposition for aspirations, like patient is in high BMI or obese patients, or there is a this thing, the other conditions where you can likely expect aspirations in these patients. Okay, so then patients, there are a few patients which you will find that they're very difficult to decannulate. Then this is commonly in case of small children, where it is better to decannulate at the earliest. Otherwise, the children become tracheostomy dependent with problems in decannulation. So please remember that. So it is when somebody asks you about the problems in a pediatric tracheostomized patients. So please remember these things. Now then some patients will have, develop tracheocutaneous fistula, and and sometimes after this thing decannulation also it might persist. So what is the treatment options? That you have to get these patients surgically close these fistulas. Okay, so then we have problems with the scars, keloid bleeding, all those things, and then tracheomalacia. Then we have got tracheoesophageal fistula, and then granulations. Now that occasionally this granulation tissue at the tip of the tracheostomy tube can bleed vigorously. So please remember that this has got other implications. The chances of bleeding is more. And this can be identified with we can use a flexible laryngoscopy and can be treated with the excision of those granulations and cauterization via bronchoscope in the operating room, not in the ICU. It is to be done in the operating room. Okay. Okay. So now we discussed about the case where we had a patient was tracheostomized and reported to the OT for putting a tracheostomy tube. Sorry, not tracheostomized, it was intubated and it came for tracheostomy tube. Now, there are some issues when you change over from the new tracheostomy to a catheter like Shelley catheter. So now we've got a case scenario. Now we've got a patient of 80-year-old man who has just undergone resections of a supraglottic mass and free transfer reconstructions. Now, at the end of the case, the surgical team wishes to extend the tracheal tube in this tracheostomy for an 8 millimeter or internal diameter Shelley catheter. Now, what are the anesthetic and airway management consideration for this case? One, and how do you manage the airway in this case? Okay. So, I think by this time you will realize that now this is a freshly tracheostomized patient. So any manipulations of the tracheostomy less than 5 to 7 days after expiation must be done with caution. Okay, so it's very fragile, and removal of an in situ tracheal tube for replacement with another device can be complicated by loss of control of the airway. So these are the biggest complications that in these conditions you might face is the loss of control of the airway. This is especially true when you are using a large and opaque device. Now, in these questions, I've mentioned about the Shelley catheter. So these are very large and very opaque. So opaque device. So basically, the flange of the catheter then can that obscure the visual guidance of the stoma recannulations. So as the in situ tube is withdrawn, the borders of the tracheostomy tract can be disrupted. And if it is disrupted, then there is chances of risk of bleeding or separation of the tissue plane. Again, that separation of tissue plane, so chances of when you try to reinsert that, there will be chances of creating a false passage and all the complications of the false passage. Since it's a fresh tracheostomy stoma, then there is chances of blood and surgical debris which can be introduced into the lower respiratory tract. Now, how to manage the airway? So the first thing is prophylactic measures to lose the airway control, because the biggest complications or the chances of loss of airway control is the most important thing. So you have to do some prophylactic measures. So now what are those? You have to consider the patient-specific characteristic. You might have to pre-oxygenate the patient. All the equipment should be ready, airway card with the tracheal hooks, tracheal tubes, and tracheal hooks actually help you to keep the margins intact. Then you have to suction the residual debris, secretions of blood that patient might aspirate. And patient might be under GA with or without muscle relaxation, so you have to consider all those things. And the monitoring part. So the vigilant is the essential part of managing these patients. And once you put the catheter, you have to confirm with the ATCO2 and the airway pressure. Sometimes you have to ignore the surgical specialist denial because sometimes the surgical operator, the apparent ease of tracheostomy, it's basically deceiving. So they might tell you, no, the tube is in the right place. But you have to just ignore that. You look at that ATCO2, if it is no or minimal ATCO2 and you have got a high airway pressure, just consider that you have lost the airway control. So this is a real emergency. Okay. So as we see in this case, the concerns are basically loss of airway control. Then you have to consider the timing. Why I'm talking about the timing? Because at the very initial stages, it is not well epithelialized. So you have to consider that. Then there's chance of bleeding. You should have a bougie or the airway exchange catheter. Actually, these things also can lead to trauma to the trachea or the posterior wall and even to the bronchi. So you have to concern all those things. Inflation of the cuff, occlusion. Sometimes you'll find that you have inflated the cuff and there is you're finding it difficult to ventilate. So chances that that cuff gets occluded against the wall of the trachea. So you can reposition that. Then you have to look for the ATCO2 and the airway leak pressure. Availability of the airway exchange catheter and a small standard tracheal tube that is a must when you're preparing for your cases. And you can check that airway exchange catheter that it passes through that in situ tube and the to be inserted tube, all those things. And the most important is here, you should cater for your jet ventilation that I have already shown you the picture. Now, what are the concerns when you're switching from Shelley catheter to a tracheal tube? The same thing I'm repeating again and again. One is your planning and preparation. Patients with an indwelling tracheostomy device like Shelley catheter presenting for surgery will typically require some manipulation of the device. So we might have to replacement with a tracheal tube. Now this tracheostomy tube not having a distal curve or it's a fenestrated, then these are not good for a positive pressure ventilation. If it is there, fine. You can go ahead with the ventilations and you can manage these patients with that tube. But if it is not there, you have to switch over to a tracheostomy tube with a curve. Determining so is the first thing is you have to determine the maturity of the tracheostomy stoma. That is the first step. And when do you consider that tracheostomy is considered mature? When there is sufficient epithelialization of the surface skin to tracheal mucosa, basically to prevent separation of tissue planes with minor trauma. Sorry. Now, when sufficient epithelialization has not occurred, manipulation may separate tissue planes and cause an intubation misadventure that already discussed about. And then the presence of tracheostomy tube can disrupt the swallowing and predisposes to aspiration and pulmonary complications. So you have to consider that sufficient adequate fasting. So we'll go as per ASA guidelines for preoperative fasting equally to patients with a tracheostomy. Some liberalization of fasting guidelines maybe we can consider for who have undergone laryngectomy. Now, if it's a non-fasted for emergency surgery or another aspiration risk, we'll just consider it as a airway tracheostomy device to tracheal tube change or something like RSI-like technique. Okay. Now, so to manage this airway, we should have a replacement tracheostomy tube. If there is an inner cannula and the operator for the in situ device, so we can use that. We'll have to remove those things first. And as I've already mentioned, that you have to keep the small or standard tracheal tubes of a smaller size, like 6, or even for an average Indian adult male, you can keep it as a 6 or 5.5 or 6.5. Now, then airway action catheters or NT catheter. So please see this picture, because you'll have a fair idea that what is this NT catheter, and you can put it into the bronchoscope. Then you can do the pre-oxygenation via tracheostomy tube. And there is no harm if there is an ENT friend is nearby, and you can request his presence in the operating room. See, safety is the first thing; it's the most important thing. So you can always ask them to be present in the OT. And once you put the tube, you can see that the proximal part of the infiltrated cup can be seen through that stoma. So these are the basic principles while managing these patients. Now, suppose this patient is presented with the stoma, and you have to you require to intubate the patient. So you can always use a tracheostomy hook. Basically the normal stoma length is around 2.56 centimeter or maybe 2.5 to 3.5, and so you have to consider the stomal length. That's basically distance from the skin to the anterior tracheal wall. See the location of the tracheostomy side, that is maybe at mid-access point in a patient's airway, as in case of patient with upper airway pathology, or maybe the terminal end of the airway. Then tracheostomy or stoma patient will present with a number of prosthetic devices or coverings. So you have to consider that this patient with metallic or plastic tubes, with or without air infiltrated curve, plastic curved or uncurved tubes. So considering all these, you can, if required. So basically that, again, the same thing, you have to plan and prepare. Now, the very interesting thing is sometimes you might be asked to prepare a patient for one lung ventilation, a patient with tracheostomy. Now, what are the anesthetic and airway management consideration for this case? Anyone, if you can answer, what are the things you're going to consider if you've been asked to do an one lung ventilation in a patient with tracheostomy? Okay, what are the procedures they are likely to do with one lung ventilation for tracheostomy? Okay, I think I'm not very clear in this thing. So basically, the most common procedure are VETs, which requires one lung ventilations to facilitate surgical exposure. And this most commonly used methods for one lung ventilation include either placement of a DLT or a bronchial blocker. So these are the conventional lung isolation technique, or we can use a wire reinforced tracheostomy tube, or there are some short DLTs. But in fact, I was just while preparing for this class, I was just going through that is actually not available in the US also. And the complications. Okay, so the most obviously the most common complication is dislodgement. So it will be sequences of events after once you lose the airway, or there is a dislodgement of the setup, or you lose the one lung ventilation. So there will be, the surgeon will be in trouble. You are in trouble. You have to reassess all the things. So one should be very careful while doing that, and this is a challenge. Okay. So now a little bit about that tracheoesophageal puncture for voice prosthesis. Now, this the basic options for post-total laryngectomy for speech rehabilitation, basically it include an artificial larynx esophageal speech, and tracheoesophageal speech. Tracheoesophageal speech. Now, out of all this, this tracheoesophageal speech provides the advantage over the other two options, that air supply for speech is pulmonary, and phonation sounds natural, and voice restoration occurs within 2 weeks. So this tracheoesophageal puncture or tracheoesophageal speech always takes an upper hand out of all these three options. So one is your artificial larynx, one is esophageal speech, one is tracheoesophageal speech. Okay. And now, during total laryngectomy, a surgical fistula is during the surgical procedure only. A surgical fistula is also created between the esophagus and the trachea. Now, a primary tracheoesophageal puncture is made. Alternatively, maybe performed a few weeks or even months after total laryngectomy. So we have got a clear idea what is primary tracheoesophageal puncture and what is secondary tracheoesophageal puncture, which is normally performed, the secondary one, which is normally performed a few weeks or even months after total laryngectomy. Okay. Now, the patency is maintained of this tracheoesophageal puncture with immediate in the immediate post-operative period using a Foley self-draining catheter or a feeding tube. So, if somebody asks you, takes a viva of the Foley catheter, you can also tell about the use of this thing. It's to maintain the patency of the tracheoesophageal puncture. Okay, and normally what happens after 2 to 3 weeks of this thing post-operative period, then appropriate size valve is inserted. That is we're going to talk about. That is the Blom-Singer valve, and in some of the books it is written as Blum-Singer, and in some of the literature they mentioned that is Blom-Singer. And if you see the company, this thing, it is Blom-Singer only. Okay, so what is this? This is a hollow 16 or 20 French silicon tube. That is a one-way flap valve. Okay, this is normally positioned with this proximal tube. It basically serves two purposes. First, it allows the patient to phonate by allowing pulmonary air to pass through the valve into the pharynx and out of the mouth. And second, it prevents saliva and oral secretion from being aspirated into the tracheobronchial tube from the pharynx. So chances of micro aspiration is very less. To phonate, the patient inhales air through the permanent stoma. It occludes the permanent stoma with the thumb and exhales. The occluded stoma basically diverts that air through the Blum-Singer prosthesis of the esophagus to the mouth. So, but it can create some complications are also seen with this Blum-Singer valve. One is chances of infection, especially the Candida infections in and around the prosthesis. It can present with some leakage through the valve due to defective one-way valve. Periprosthetic leakage, then occlusion of the prosthesis, and inadvertent displacement and aspiration. So
our next question is, what to do if a patient presents with a displaced Blum-Singer valve? So you can type your answers in the chat box, please. What to do if a patient presents with a displaced Blum-Singer valve?
I think all have become hypoglycemic.
Any answers? No, we don't have any answers for this.
No issues. So basically, there are two main problems that we encountered. So now I've just mentioned about the advantages of this valve. So obviously when the patient is displaced Blum-Singer valve, so the patient maybe aspirated in the tracheobronchial tree. That's what I have mentioned as an advantage. Am I audible?
You're audible, sir.
Okay, thank you, ma'am. So first is that oral secretion may be aspirated into the tracheobronchial tree, and secondly, the tracheoesophageal puncture may seal spontaneously. So basically, it demands for another surgical procedure. But what will you do if you don't have an ENT services nearby, or so the same thing that I have mentioned in this thing at the initial stage you do. It's a self-retaining Foley's catheter. And the ideal size should be that it's equivalent to the size of that Blumsinger valve. And it can be introduced through the TEP into the esophagus under local anesthetic spray. Balloon is inflated with around 3 ml of air, gently retracted and tapped to the side of the neck. And just shift the patient, transfer the patient to a center where you have better surgical facilities, or you've got ENT surgeon. So please, if you want to do very well in your exams, you should know all these things, and these are given in your standard textbook. Okay, so okay, so now I'm not going to details. You might be asked about this thing, care of tracheostomy, and because these will tell the examiner that you have adequate exposure for managing a patient with tracheostomy or not. So one is your constant supervision. You just look out for the bleeding, displacement, and blocking of the tube to the secretions. As the patient is unable to speak, a calling bell, paper, or pencil should be given to him if he is ever. Then removal of secretions. Excess secretions occur following tracheostomy, and trachea is as trachea is exposed to basically non-humidified and non-air conditioned room air. Now, this secretion should be removed after every half hour initially, and then hourly by sections on the very first day. Then you can, whenever you do some procedures, strict sterile precautions should be taken by the attending staff to avoid lung infections. Separate suction cannula should be used for tracheal and oral suctions. And installation of solutions like soda bica, normal saline, or mucolytic agents, acetylcysteine, NEC. So all these things you should know when you are answering for your care of the tracheostomy patient. Now, this is a very favorite question. I've seen examiners are very fond of asking, okay, आप कैसे suction करते हो and all those things. What is the pressure? So please, people must be doing it in your institute, but please have a fair idea how to answer, how to frame your answer. So basically, you attach the catheter to the suction machine and don't touch the end of which is going to the tracheostomy tube. So if you tell this, the examiner will be very happy, because they will come to know, yes, this guy is actually working in the in an aesthetic manner. And then the suction machine is around 50 to 100, but for in standard books it is mentioned as around 100 to 120. So you can talk anything about 80 to 120. That will be good enough. So before going into the suctioning, test whether the catheter is working or not. You can dip the tip of the catheter into a cup of sterile water. Normally, you can avoid that. Pinch the catheter or the uncovering. So you require at least two guys. You know, while twirling the catheter, we do it to remove the mucus. Don't keep the catheter in place for more than 5 to 10 seconds at a time. And you can ask the patient to take deep breaths after suctioning if the patient is cooperating. Okay, so now, if your viva is going into that, now they might ask you about the humidification part, care of the cuff tube. Now, why humidification is important? Because it is essential to prevent the crusting of the secretions and irritation of the tracheal mucosa. It can be done by using of humidifiers. You can cover the tracheostomy tube opening with an 8-layered gauze moistened with saline, installing a few drops of normal saline down the tube at regular intervals. All those things. Then care of the cuff tube. Cuff of the tube should be deflated at regular intervals for 10 minutes every 2 hours to prevent pressure necrosis of the trachea. Suction, as I've already mentioned, that you have to be very thorough about that, answering about the suction part. The suction should be done after deflating the tube, so the secretion which accumulate above the cuff can be sucked out. Then you have to take care of that cotton ties or Velcro traps that to be changed or soiled or wet. So all those things. Then changing of the tube. So it is recommended that tracheostomies without inner tubes we change every 7 to 14 days with the frequency of decreasing it, decreasing as the stoma becomes better formed and pulmonary secretion decrease. So other than this, please read about something about the tracheostomy revisions and timing of the tracheostomy for prolonged ventilation. Then it is actually debatable, but you can read about that. There are a few studies, and there one study that I'm very happy if you talk about that Trackman study. And coming to that, I have not discussed about the tracheostomy in pediatric population. So if we see that indications for the most common indications of pediatric tracheostomy, nowadays it is the most common is the congenital craniofacial causes of airway obstructions, and it can be it is a frightening experience for the patient, for the baby, or for the parents. And I have already mentioned that single most important risk and the greatest cause of morbidity in these patients are because of that accidental dislodgement or the obstruction of the tube. So you can read about that. There are very good articles on that. So basically, you have to know that indications and contraindications. So initial indications, and if you go back to the history of the pediatric tracheostomy in pediatric cases, then diphtheria used to be the most common causes. Then comes that bulbar poliomyelitis, where to clear that bronchial tree, the pediatric patients got exposed to tracheostomy, basically managing patients with bulbar poliomyelitis. Subsequently, it is become for the management of patients with neurological problems, tetanus, chest diseases, extensive burns, etc. And so current indications are mainly for this thing, acquired subglottic stenosis. Patient might go for the surgery for that, which is a single stage laryngotracheal reconstruction surgery, and also for the subglottic hemangiomas. So all these things might be asked. And then when I talk about the complex craniofacial anomalies, the most common causes out of that is your Pierre-Robin syndrome, where and the most the culprit in out of this all these features of the Pierre-Robin syndrome is your micrognathia. So and then something about the tube selections. Tube should be very soft. Not should that is yes. If it is become too soft, then it can lead to airway compromise. So you know that tube should be soft, but that shouldn't be too soft. Then about the length of the tracheal tube. Then people are using some metallic tubes or plastic tubes. What are the advantages of metallic tubes? So basically, it can there's an inner tube that can be removed and cleaned. And also try to know about something about the valves or about the tubes which helps the children in speaking, like elder hair tubes. And then other tubes are Negas tubes, Chevalier Jackson. Also you can read about those things. Now coming to that decannulation of the patient with a long-standing tracheostomy. So basically, the tracheostomy should be removed as soon as feasible. Decannulation basically allows the patient to resume breathing through the upper airway and reduces the dependence, psychological and otherwise. And then you can give a trial for that. It just increase the period of cough depletion that you must be doing in your ICUs. So you have to assess by various techniques whether the patient is adequately breathing or not. This cough depletion technique is basically allows the patient to reaccustom with the swallowing more normally and having to clear their own secretions. What is the alternative technique? You can use an occlusion cap, which completely blocks the tracheostomy tube. Of course, this must be used with a fenestrated tube or an unfenestrated tube with the cuff deflated. So if you're using occlusion cap, it's better if you use a fenestrated tube. If not a fenestrated tube, then just ensure that the cuff is deflated. Okay, because that will greatly increase the work of breathing, because of decreased airway resistance. Now it will be harder for the patients to breathe in this situation than without the tracheostomy in place, and this must be taken into account when while interpreting the success or failure of this trial. Okay, so decannulation can be carried out when patient is not dependent on ventilatory support. There is an adequate respiratory reserve. Patient is able to cough and swallow effectively and manage their own secretions, able to protect their own airway. Patient can tolerate cough deflations or capping of the tracheostomy tube, as we have already discussed. Now, and this trial should be done in the morning hours, and you can review their progress in the daylight. So, but by evening, you should be able to assess that whether the patient is actually tolerating that or not. Stoma should covered with a semi-permeable dressings. You always encourage encouraged to gently press over the defect while speaking or coughing. You to monitor for the signs of respiratory distress, and whenever you are dealing with the tracheostomy patients, for whatever reasons, you'll have to be ready with the equipment and expertise to resecure the airway. Okay, so just to test our knowledge, I think I've spoken a lot.
Yes. So,
Yeah. Just
can I read it for you,
true or
sir?
false.
Yeah, so we have true and false questions. So just say true or false. For a pediatric tracheostomy case, at home, a child with a new tracheostomy should sleep near the parents. Is it true or false? The answers, please. So Dr. Rohit says, Dr. Sanjay says it's true.
Yeah, actually, now a patient with a new tracheostomy should sleep near the parents. Basically, this allows the parent to become familiar with the noises that the child makes, and to become accustomed to the frequency of suction required. This is a very important topic when you are dealing with the patients, pediatric patients with tracheostomy tube. This is called something health-related quality of life. So where you consider about that aphonia, then swallowing difficulties, then sleep and supervision, because ultimately the parent is going to take care of that. And yes, I know that the patients will have to be initially for the high dependency units or then an environment. So once the patient or the child starts sleeping with the parents, and very soon parents become acutely aware of any change in the child conditions. Okay, ma'am, can you go to the second thing?
So the next one is, mainstream school should be the aim for a child with the tracheostomy. Is it true or false? The child with tracheostomy, we should aim him for a mainstream school. Any answers? So Dr. Rohit says it's false.
Okay.
Dr. Zoya says it's false.
Okay. Thank you, Rohit. I think answer is actually it is true. Mainstream school should be the aim for a child with tracheostomy. The opportunity basically to meet the child is extremely valuable for teachers with the help of the community tracheostomy care. When we talk about these things, actually, this is the Western world. They give us the idea of managing patients. So they have got this thing, tracheostomy nurse and the community pediatricians. I know it's very difficult when you try to visualize the school conditions in our setup, but this is the standard of care. Okay, so the basically mainstream school should be the aim for a child with tracheostomy. Okay, so the next one is
swimming is forbidden with tracheostomy. Is it true or false? Dr. Sanjay says it's true.
sorry, ma'am.
The answers are coming true. Dr. Sanjay, Dr. Zoya,
so actually it's very interesting that swimming is forbidden, but child may paddle up under supervision. And then the next thing that should come to your mind, okay, what are the techniques that they normally deploy or they teach the parents how to take how to give a birth to the child? So basically this is a supervised this thing. Hair should be washed. Hair should be washed with the child sitting in upright in bath, and a jug or shower attachment. The direction of water should be as if the water should flow down the child's back. So the training should be given. So it's a actually that pediatric cases, it's very it's a team effort. Okay, so now coming to the next thing. Yes, ma'am.
Yeah. So this is also true and false, sir?
Yes, ma'am. Yes, ma'am. That's the same.
Okay. So you have to state whether it is true or false. Fenestrated tube has an opening in the posterior part of the outer tube. So we are getting the answers as true.
Okay. Okay. Yes. I think I already mentioned about that in our presentations. What about the number 2? That if the tube is cuffed and
the tube is cuffed, the fenestration lies above the cuff. Is it true or false? in a cuff tube, the fenestrations, yeah, it's true.
Yeah.
Dr. Rohit has said
So,
it's true.
yes. So please remember that we might have this thing now. We might get tracheostomy tube with cuff, and that is fenestrated also. So this fenestration actually normally lies above the cuff. So why do we require to know about all these things? Because when this patient reaches to the OT or in the ICU, you are the one, you won't get the primary surgeon who is put up that who placed that tracheostomy tube. So you must know all these things. It's excellent. So next thing is our
Maximal, the next one is maximal airflow through the upper airways is better during speech. Is it true or false?
Okay.
So they're getting answers as true.
Yeah. So in fact, I think I'm a very poor in framing questions. Almost all the answers are true. This maximal, yes, it is right. The maximal airflow through the upper air, that is what you are looking for better, because that will give a better quality of speech. Okay, and
the next is for positive pressure ventilation, the fenestrated inner tube should be changed. Is it true or false? So the answer is true.
Yeah. So as I've told you, okay, I'm very poor in framing questions. So all the answers are true. Yes, the fenestrated inner tube should be changed, because if there is a fenestration, then definitely you are going to get some leak and you won't be able to deliver that exact tidal volume what you want to. So this should be changed. And so I think, okay. So before just this thing finishing our presentations or discussion, now this is a very important thing because you might get a patient with a dislodged tracheostomy tube. So I have just put up in this thing algorithm that will definitely help you. So if it is, first you have to consider that it's malpositioned. So you look at the respiratory rate, at the amount of distress, then look at the set. If there is sudden decrease in tidal volume, loss of anterior carbon, etc. So you know that there is a tracheostomy is dislodged. So you call consultant. Call for help is the first thing that you do. Now, does the patient require immediate action? No, then you can still wait, because if they're still maintaining that good amount of saturations and yes, distress is there. You have already alerted the this thing team. But if it is this thing, patient require immediate action. So first you have to see that what type of tracheostomy was done. Is it surgical or percutaneous? So there comes that if it's a surgical and as for percutaneous, if performed using walk flap, consider the following. So that's what we have told at the very beginning while presenting, that U flap, walk flap, and that circular. And so remove the tracheostomy tube. Then use stage suture to open the tracheal tube. Might be because of some this thing, there is a tight this thing suturing, and reinsert the tracheostomy tube, sometimes just simply extending the neck might help. So you can do those things. If it's a percutaneous and it's less than 14 days, so you can see that patient is ventilated. Do the same thing and remove the tracheostomy tube, cover the wound with this thing, some dressings. You can establish the airway, and you can also use a supraglottic device. Now, if the patient is spontaneously breathing, you can deflate the tracheostomy cuff. You can allow the patient to breathe through the mouth. You can give 100% oxygen, consider jaw thrust, or use an oropharyngeal airway to improve the tidal volume. Now, if this tracheostomy it's more than 14 days. So ideally, mature tract should be present. So you can insert a bougie or suction catheter down that. You can remove the tracheostomy tube and can try to insert a new tube. So idea is that if it is less than 14 days, don't try to put a new tube. And you can do the same thing. You can extend the neck, and that might help. You can consider to use a downsizing of the tube. If it is a 7.5, you can try to use a 7 size or 6.5. So, and in everywhere, it has been mentioned that you can attempt only once. You check the ATCO2 waveform and call the consultant. Okay, so this is a real emergency. Okay, okay. So now you can shoot me.
Very elaborate talk, sir. Thank you so much. So we'll take up the queries now. And I think one of the queries by Dr. Sanjay Gupta, what to do during accidental extubation of tracheostomy tube. I think sir has just answered with that algorithm.
Yes.
So I think you got your answer, Dr. Sanjay. We'll take up the other queries. Our first question is, in percutaneous tracheostomy, what is preferred initially, single lumen tube or a double lumen tube? And when to replace the first tube?
Yeah, that's what we have discussed. No? So normally we use a single lumen, and then we switch over this thing after, not before 72 hours. So, and first we go with this thing single lumen, and ideally it should not be this thing not to be changed within first 72 hours. That's what that guideline says.
So that is, yeah, that's the answer. The next question is, how long should we wait to for the tracheal passage to form? Like for how many days we should be cautious about the spilling out?
Important questions, because that actually tells you about that you can if it is a well epithelialized, the tract is formed, the stoma is formed, so you can avoid this thing creating a false passage. And normally it takes normal 7 to 14 days. So that's why they're told that if you do it after 14 days, the chances of and if you can see in this algorithm also that the 14 figure is there if it is less than 14 days or more than 14 days. So if it is more than 14 days or 2 weeks, so chances of that the tract is already formed.
So the next question is, what is the ideal cuff pressure to be maintained for tracheostomy tubes?
Yeah, so ideal cuff pressure, that it is normally we keep it around less than 25. And see what we do in our ICUs, we always use a cuff pressure monitor, and we check it every time, because we have to deflate it every 2 hourly in the initial stages. So you always check it, and it's always a good idea to maintain that pressure cuff monitor, and you keep it somewhere around 20 to 25 or less than that. Because that anything that crosses the 25, then there is chances of mucosal necrosis is more. You don't want to do that.
Thank you so much, sir. I think due to shortage of time, we have to wind up now. Over to you, Naveen, sir.
Thank you, Dr. Debashish, for an elaborate talk on tracheostomy. It was pleasure listening to you, and I hope all of you must have enjoyed listening to Dr. Debashish, and we'll like to soon have you with us again for another interesting class. And please have a good cup of coffee or tea, because we have been speaking for around 2 hours now. And thank you for sharing your experience and knowledge about tracheostomy with us.
Thank you, sir. Thank you for giving me this opportunity, sir. Thank you.
It's our pleasure. So see you all next Monday for another class. It will be on coronary circulation and anesthesiologist by Dr. Ranjit Karthikeyan from Chennai. Thank you very much.